So can we start? It's fine.
Yeah, I think that we can start. I know that Dr. Toglietti is going to be connecting anytime soon, but it's okay to start so we don't go over time, particularly to the guests for the speakers in North America, and because they have their scheduled surgery. Thank you.
Okay.
Thank you, Dr. Signa.
Also, first, on behalf of WFNS Neuro-rehabilitation and Reconstructive Neurosurgery Committee, which is joined with the AASNS, I welcome all the speakers, moderators, and panelists. So the theme of this webinar is reconstruction technique in skull-based surgery. So we have 4 speakers, two from US, 2 from Italy, and Dr. Olivier introduced them. And we have 4 topic of presentation. All speaker will begin 15 minutes, and question and answer will be at the end of the presentations. We have 2 moderators, myself, VD Sinha from India, and Dr. Armando from Mexico. And our panelist is Dr. Ali, and I'm Olivi, and I'm very thankful to you, Dr. Olivi, for your coordinating and managing this webinar. And over to Dr. Olivi, please start.
Very good, very good, Dr. Signa. It's a pleasure not only to organize this webinar. I know that Dr. Signa was certainly the person that coordinated with me this webinar, but I'm extremely happy to have the speakers. We have an outstanding panel of speakers today. As you said, Dr. Signa, 2 from North America and 2 from Italy. And they're going to all develop the topic that we indicated as a part of our webinar, the reconstruction techniques in skull-based surgery. So without further ado, I would like to introduce the first speaker, who is Raj Mukherjee. That he's a faculty member and the professor at the Johns Hopkins University, my professional alma mater, and he is the chief of the neuro-oncology division at the Johns Hopkins Bayview Hospital. And it is for me a pleasure to introduce him for the topic of optimizing quality of life and minimizing morbidity through skull-based surgery reconstruction. So Raj, welcome to this webinar. We're very pleased to have you as a part of this outstanding group. Thank you.
Thank you. Thank you so much, Dr. Olivi, Dr. Sinha, all the organizers for the opportunity. I will share, actually, if I can share my slides. I think a request was just sent to share slides. There we go. Great. Thank you. Thank you so much. So, I know we're going to have other speakers talking about, the thought process by which we will, can close skull-based procedures and think about different kinds of pedicalized flaps endonasally and externally. But I figured I would take a little bit of a different approach to kind of put things in context for how we think about quality and minimizing morbidity more broadly. And so, I have some disclosures, but really nothing relevant here for the presentation. I think when we think about quality of life, I think we can think about it in broad terms in terms of what we know about quality of life, how we measure it, and how we define it. If there are areas that we can improve upon, particularly when it comes to olfactory loss and gustatory loss, and a lot of those are very approach specific, especially as endoscopic and nasal approaches have really taken off in the last 20 plus years. And then a couple sort of parting thoughts on where we're going in terms of new quality of life instruments and maybe even interventions to help for those patients that have perturbations in their neurological function. So we know that some of the endoscopic and nasal approaches have some advantages, some distinct advantages relative to maybe open cranial approaches. It could be debated whether you can have improved surgical outcomes. I think when it comes to, for instance, tuberculum cell meningiomas, there's, I think, reasonable data from multiple centers that vision outcomes are at least comparable and in some hands better with endoscopic and nasal approaches than open approaches. It obviously depends on the specifics of the tumor, but we can have improved visualization, especially in the ventral aspect of the brain, and depending on the complications, decreased risks at least of seizures and cosmetic issues with open cranial approaches. And as long as there isn't a CSF leak, there's good data that show that patients have decreased length of stay. But there are a lot of disadvantages that, especially as neurosurgeons, we don't often think of, but can be really devastating for patients. And so there are unique morbidities and unique quality of life perturbations, even in routine cases. And so some of that comes just from having our suctions or our instruments damage some of the mucosa and turbinates. Even taking off the mucosa from the sella can cause some scarring. And in long cases, oftentimes if we're not thoughtful about irrigating that nasal corridor, you can have a lot of drying of the mucosa that can cause a lot of scarring later on. And so even though it is quote unquote minimally invasive, it could potentially be really maximally destructive, at least to some of the mucosa and some of the structures that maybe we don't think about as often as neurosurgeons. So there's obvious implications to the pathology, local compression on vision nerve and carotid arteries with vision loss and endocrine abnormalities. But there are implications for accessing that sinonasal corridor. Most often nasal crusting and obstruction and drainage and olfactory disturbances, even in patients where we're not in the anterior cranial fossa. There can be septal perforations and even cosmetic deformities. And there's particularly a great series that was published in about 2016 from UPMC that shows that when you do some of these more extended approaches for closure, including a nasal septal flap, you can actually have a saddle deformity in part of your nose. And so I think being thoughtful of some of those risks and benefits and being thoughtful about that stepwise approach of when you actually need a nasal septal flap or not can hopefully help minimize some of these unnecessary deformities and complications. And this is from a patient that one of my early patients that had this was imaging, endonasal imaging that was done about 2 or 3 weeks after surgery. And you can see a lot of this crusting that was really painful and problematic for the patient. So what we know about quality of life in these skull-based cases is that it is an extra measure of surgical success. So, traditionally we would think about survival, overall survival, progression-free survival, local survival, complications, including CSF leak and length of stay. But what patients are often most concerned about is, frankly, their quality of life and their day-to-day function. And that's particularly important because such a large proportion of our endoscopic, endonasal, or skull-based cases are for really benign pathologies, pituitary pathologies. So it really forces us, I think, to raise the bar and help ensure that we're really minimizing morbidity. In terms of how we assess quality of life, historically, surgeons have been the ones that have measured those benchmarks. But I think increasingly there's a push to have patient-reported outcomes, and there's lots of different types of quality of life instruments that are out there. They're general and disease-specific, symptom-specific, including, for instance, vision, and approach-specific, which is probably most relevant to us as surgeons. I think depending on the region in which you're operating, you can make a direct correlation with the different types of neurovascular issues and complications a patient can have. In the cellular and paracellular region, you can have a significant amount in sinonasal quality of life detriments, even without getting into the olfactory fibers. And obviously you can have, dry eye and, numbness and God forbid, neurovascular injury. In terms of the quality of life assessment tools that are available, I think an important one that has been often used in the skull-based literature, particularly in rhinology, is the SNOT-22. It is a quite long quality of life instrument. So it's about 110 different, it's a scale that goes from 0 to 110 with 22 different instruments in it. And this shows, I think, the typical pattern, and this is from a meta-analysis done by the Medical University of South Carolina, that really shows over time, within the first week, we expect most patients to actually do worse. A higher SNOT score is worse. And then there's an MCID of 9 points. So significantly worse sinonasal morbidity within the first month. but typically by months 3, 6, and 12, patients get back to their baseline, particularly if they had poor scores, not 22 scores over 20, which means they were more symptomatic at baseline. Some people may wonder, well, what happened here multiple years out? And this is just an outlier. This is just one paper that had a particularly, a small series of patients that had long-term outcomes. But I think the general trend shows, within that first month, we need to be cautious that almost all patients are going to have some issues, including some of these, some of this local trauma. But by the time you get out to 3 months or more, things typically heal over as long as you're taking some of the usual precautions. A nice review was done by Jim Evans and the team in Philadelphia that looked at the utility of this NOD22 because it does take so long for patients. And what they found was really 50% of the items had no change over time. And so, I think we need to be thoughtful as a neurosurgical society of what we have our patients spend time on. As we think about different kinds of instruments, it's important to hopefully have instruments that actually tell us things that are relevant to us and to patients, including visual outcomes, endocrine outcomes, and longer term, outcomes. Several tools exist to look at quality of life, and I think a nice review was done by our group along with the Mayo Clinic group when Dr. Chobe was there. I think these are some of the instruments that are used across the world nowadays. But you can see if you did all of these together, it would take you, a good portion of the time that you would actually be doing surgery would be taken up doing some of these quality of life instruments. I think practically speaking, the skull base inventory is widely used. And for those that are interested in monitoring their patient's own nasal outcomes, I think the AASNS is very short, 12 instruments, and it just takes 2 minutes. It's something that's routine for us here at Hopkins. In terms of other things that we may be missing, olfaction and the importance of olfaction really can't be understated. Again, this is something I never thought of really when I was starting out, but it has to, it has a lot of impact on, smell and taste are very much associated. It can be a health hazard if you don't have a sense of smell, and it really can cause a lot of depression and anxiety, and that's been noted in many patients with sinonasal tumors. I think, some of these questionnaires can be very heterogeneous, as has been noted in multiple reviews. And I think one thing that we can very practically do for our patients is be very careful, even when we're not doing full nasoseptal flaps and only doing rescue flaps, for pituitary adenomas, to really make sure that we don't strip the strip the superior olfactory strip. It's basically this area right here. I think, as neurosurgeons, sometimes we just want to get to the cella and get to our work. But about 5% of patients will have long-term smell issues and hyposmia just from that kind of perturbation. I think in addition to smell, I think taste is its own, gustatory function is its own unique problem, I think, for some patients. And this was our series at Hopkins that noted a similar kind of trajectory with worsening in the first couple of weeks and normalization in most patients by the time they see us at that 3-month mark. So I think, it's helpful to let patients know what to expect. I think each of these approaches gives us opportunities to intervene. And my last little thoughts as time sort of runs out is ways that we can think about actually improving our patients day to day. So at Hopkins, we use this device called a Spyway device, and I'm not a consultant for them, but it is a plastinated device that helps us protect some of the mucosa. As we approach the cella, we found in a small series that it's improved our mucosal trauma, and it's actually improved our patients' quality of life, and that's in some work that's been currently in review. There are lots of different teams across the country and the world that are looking at different donor sites. What we use at our site is not a graft, but a porcine graft, but instead we use just a middle turbinate graft to cover the donor site for the nasal septal flap, and that's been seemingly helpful for our quality of life outcomes. And then I think there are groups, for instance, at Stanford that have looked at medical management, including use of omega-3 supplementation to help with smell dysfunction following skull-base surgery. So hopefully this has been a little bit of an overview when it comes to specifically that topic of quality of life, why it's important and how we measure it, and maybe some interesting technical bits on how we can either with medicine or with intraoperative adjuncts help our patients feel better beyond taking out their tumors. Hopefully, because we're all in our own little silos, it's often difficult to gather enough, to accrue enough patients to actually power these studies. But hopefully through groups like this, we can connect with each other and work on some of these projects in a multidisciplinary fashion. It's a multidisciplinary team at Hopkins, including neurosurgery, ENT, our endocrinology team, our ophthalmology colleagues, and our radiation folks for those that have recurrent or progressive problems. And I'm delighted to work with them and delighted to be here and to hear others' thoughts. So thanks so much for the opportunity.
Thank you so much, Raj, for this presentation. Very eye-opening for a number of reasons. I would definitely ask if anybody has questions to ask now to Dr. Mukherjee, because he has a commitment in the operating room and he has to leave probably before the end of the webinar. So if anybody has questions, I would encourage you to ask Raj now instead of the end of the webinar. Anybody has questions?
Dr. Raj, can you hear me?
Yes.
Hello. Yeah, I want to ask about this approach and post-operative morbidity. Are we doing over or we should restrict?
In terms of their physical activity?
Yeah, no, in terms of morbidity, overall morbidity, what you mentioned,
Yeah.
should we restrict this approach and we go for the traditional approach, transcranial, or what is your opinion for young generation?
Yeah, so the way I was taught is you should never alter your opening. You should never minimize your opening. So that you have an easier closure, or so that you minimize that morbidity. The core issue is to take care of the tumor, especially for malignancies. The core issue is to take care of the tumor. I think we just need to be a bit more thoughtful about how we address those known morbidities that are going to happen. Again, about 5% of the time, even with a simple procedure, people are going to have some smell issues. But I think, that's for pituitary adenomas. As you get, I think, as you get to, for instance, like an olfactory groove meningioma, I think the thought process is very much, at least for me, is very much dependent on, whether a person has functional smell or not. And so, if someone has a functional smell, personally, I wouldn't do an endoscopic and a nasal approach and take their smell. I would think about a bicoronal or terional or whatever your cranial, choice du jour is. And so I think that, practically speaking, is how I work that through my algorithm. Not to be conscious of morbidities and to address them and to be thoughtful about them when you can upfront in your surgical approach.
Raj, you anticipated a little bit my question, Raj, which is, of course, something that I experienced personally, the different approach on some meningiomas of the skull base, whether they are infracranial or transsphenoidal. The technique of visualization and illumination I've encouraged very much, and I have certainly not, I'm favorable in many situations, but it will be very interesting to see the outcome, because not always when you do intracranial you preserve the olfactory. I've seen that the teronial approach sometimes has an advantage in saving, particularly the contralateral, one of the olfactory nerves contralaterally, one of the olfactory tracts. But certainly this could come into a decision-making process when you want to preserve something that probably in the past has been overlooked, and that the preservation at any cost, as you mentioned, for the impact of the quality of life of the olfactory property.
Yeah.
What is your feeling about the two approaches, of course, which is the old questions, of course. The old question.
Yeah, completely agree with all of those thoughts. You know, Michael McDermott had a paper, for instance, for tuberculum angiomas that came out maybe 5-6 years ago at this point,
Yes.
with even a grading system. And so the tricky part with that particular grading system is that when you look at it, it basically comes down to if you have a really, really small O-factor groove meningioma, or tuberculum, it was actually tuberculum angiomas. It was really, really small, but between the optic canals, endoscopic endonasal was great. And for everything else, it was supposed to be open. I think when you look at other series, though, the visual outcomes for endoscopic endonasal approaches are better, I think, than at least when you look across series than when you do it open. And I think it makes sense when you're doing it open, you are working around the optic nerve as opposed to endoscopic endonasal. The last thing you see is the optic nerve. So I think that work from Dr. McDermott was a good example of not just looking at his center, but it was a multi-center collaborative to try and really understand in different people's hands with that collective experience, where does the needle fall? And then obviously at any one individual surgeon or any individual institution has to do what's best, what they feel most comfortable with. But I thought that was the best example that I know of in the literature of actually doing a thoughtful comparison, and hopefully we can do that with other tumor types like craniopharyngiomas and active groove meningiomas and the like.
Thank you, Raj. Are there any other questions? If not,
can I make a comment?
Yes,
also?
Mario Rigante.
I'm ENT, so I think I'm the only ENT in the group. So I'm really like this presentation because we are really agree with the issue of quality of life, especially in this patient, especially when we work through the nose. The patient asks us to do medication, and not only some crusting, also the problems are related in the post-operative period, especially are missed. So we need to speak well with patient about this argument. And I think we need to focus in different pathology because you speak well about tuberculum cell meningioma. You can do it transnasally, but you need to remember that to close the defect, you need to harvest flaps. And then when you harvest flaps, especially pedigree 1, you can damage the olfactor even through the nose. So you have to speak well with the patient. Also in what we call minimally invasive approach, sometimes they're like to putting a bomb in the nose. So you have an empty nose and that it provides a lot of problem also to the patient. So I'm really happy that you mentioned this quality of life issue because for my part is one of the important issue and when we need to discuss when we start our decision making in doing the special approach for the special patient and for that pathology. This probably I will focus on also on the addition in my presentation, but I'm really happy that Dr. Ray speak about that because sometimes we miss this topic that is quite paramount important after the months they came and the patient comes to you with that problems. You need to explain that before the surgery you can have this kind of problem. If we got a guidelines so we can share our experience with each other, I think will be a good way to tell the patient well what can happen and what kind of approach can lead with kind of problem in terms also of quality of life issue. Obviously, we need to think about oncological outcome, however, but just explain them and discuss between us which is the best approach. Also, in this term, it should be an idea. Thanks.
Thank you, Mario. I think we have to move on both to free Raj so he can go to his case, the surgical case, and then proceed with the next speaker that I'm very, very happy to introduce, Pablo Recinos. He is a professor of neurological surgery at the Cleveland Clinic. He's a co-director of the cranial base and pituitary surgery program. And more than anything else, he is an alumnus from my alma mater at Johns Hopkins and a great friend. So I'm very excited to have him as a part of this outstanding group of speakers. Pablo, I know that you are also in Brazil, so it's also probably the hour is not the best for you, but thank you for being with us and thank you in advance for your presentation, Pablo.
Oh, I'm delighted to be here, and the hour is perfectly fine. It started at 8:30, so no problem from my standpoint. Can you see my slides at the moment?
Absolutely, yes.
Okay, so I'm going to talk about reconstruction. I know this is the topic, but applying this reconstructive ladder concept, I'm really going to focus on endoscopic skull-based cases, but the principles apply regardless. Here's an overview and objectives of what we're going to talk about. We're going to talk about what is this ladder. We're going to talk about techniques beyond, in particular, the nasoseptal flap, which is a workhorse for endoscopic skull-based surgery, and then explore some evolving strategies on de-escalating our reconstructive needs. And I'll get to that at the end. This is a book that was published by my partners Raj Sandwani and Chris Roxbury on CSF rhinorrhea. I can tell you as a neurosurgeon, here's my opinion on this, is like how to stamp out CSF rhinorrhea. So that's really the point of this talk. The first thing to really think about is that not all skull-based defects are equal. Here we can see on the left a sellar defect, diaphragm intact. On the right, an anterior skull-based defect where we have a large dural defect and an exposed brain. So how do we think about this, and what are the challenges? Endoscopically, they can be more complex. Watertight reconstruction is challenging, especially as suturing, I would say, is uncommonly done. We see it in with some of our Asian colleagues that will do this. But in general, it's a challenging thing. And of course, if somebody has a postoperative leak, the impact can be significant. So from a patient standpoint, it can require multiple hospital readmissions, revision surgery. And from a financial standpoint, at least from our data, a revision surgery can cost up to 60% of the original procedure. So it's not a financially great option for the hospital for us. So doing it right the first time is key. How do we decide? There are many factors: patient factors, tumor factors, size factors, and then the specific leak type. Is there a leak? And if there is, if it's low flow, if it's high flow. This is just a table which discusses some of the options based on leak type. But here we'll introduce this concept of the reconstructive ladder. So this is what it is. It's really starting from the bottom, from no repair, all the way up through the different grafts and flaps. And at the very top and most complex is free tissue transfer. So let's start at the bottom of the ladder. What type of cases would we do no repair? Well, this is an example, an endoscopic and nasal odontoidectomy. This was done for pseudo gout. Here we can see we've split open the buccopharyngeal fascia. We've drilled the C1 arch, and we're drilling the dens. And even though we may remove a little bit of the pannus that has formed, this is a circumstance where we anticipate that we won't have a leak. So this is one where we would not have to do any type of repair other than just reapproximating the musculature at the back. Moving up, so free grafts, we have autografts or allografts. We have different sources that are made from different things. We can use them as a single or multi-layer configuration. Here's an example. Here's kind of the setting of how we think of the layers. Here we're looking at a sellar defect. We can see the diaphragma sella there intact after resection of a large pituitary tumor. But what are the other layers? Well, this is the dura here, and here is the outer bony defect. So how can we fill it? Well, one way we can put an inlay graft, so so-called subdural inlay graft, as you can see. We can use an epidural inlay graft. This is an option that we'll frequently use if there's a nice bony edge to tuck in, because then when with gravity, when gravity presses forward, the graft is still secure. Or you can place things in onlay fashion. So this is on top of the bone after the bony defect has been cleared off. So fascia lata has been a workhorse for a long time. It was originally described for repair in cranial surgery in 1926 by Walter Dandy while he was at Johns Hopkins. And certainly it has many advantages. It's very sticky and pliable. We can sew it together. Here we've made a button graft. So we've stuck one in the subdural space and then the other one is an onlay covering. And so you can do a lot of different things for it. But what are some of the disadvantages of it? I'm sorry, it can certainly act as a role in augmenting as a nasoseptal flap, or even in certain select cases instead of a nasoseptal flap. We don't actually often use the fascia lata at Cleveland Clinic, mainly because of it does come with some consequence, pain, for example, in the area. But this was a series that we looked at our 50 consecutive cases. 13 were revision cases. Most of these all fell into the more complicated reason in a situation where we couldn't use or felt that using a fascia lata was more important than a dural substitute as the initial layer. And in general, it's a very good option that can be used in certain reconstructions. We only had one post-op seroma, for example, but good salvage option in that case. So moving up, then we get into vascularized tissue, so the flaps. We'll hear about that more later from Dr. Riganti, but I do want to just mention a few things. This is really the nasoseptal flap changed endoscopic skull base surgery dramatically. In 2006 was the first description by Haddad and Bastagastegui, and really the concept was how to preserve the vascular supply to the nasoseptal flap and rotate it up so it's remains a vascularized tissue. Here we can see a case of a giant macroadenoma with extension pressing up the suprasellar space. The patient presented with obstructive hydrocephalus. And here, clearly, we are in the basal cisterns. This is a situation where we have a high flow CSF leak, and we put an initial repair. There's a synthetic button graft that we placed, and then finally placing the nasal septal flap. So the nasal septal flap here is really that gold standard vascularized tissue that is going to allow us to do this type of case while still minimize the risk of a postoperative CSF leak. What if we look beyond the nasal septal flap into these regional pedicle flaps? You're going to hear about the temporal parietal flap at the end I think by Dr. Dolieto, so I won't focus on that. But we know that in open cranial surgery, the pericranial flap is certainly a workhorse and gold standard. I know working with Dr. Olivi years ago, we did a lot of this for vascularized tissue. But when I was at North Carolina, I had the pleasure of working with my mentors, Adams and Nation, and learned about how to apply the same concept endonasally to tunnel and a pericranial flap endonasally. And sometimes we have to do that. This is an example of recurrent pituitary adenoma. The nasoseptal flap options had been taken out by all previous surgery. And so we had to think outside the box. Certainly you could say, okay, can you approach this transcranially? Yes. But we felt that from a tumor access standpoint, the best and most direct route was still endonasally. So this is where we selected to do a pericranial flap for reconstruction. As you saw a little bit ago, it requires you to connect the frontal sinuses first. After tunneling the pericranial flap out through an incision, the glabella, then you can tunnel it in. And this is at 6 weeks post-op, demonstrating excellent integration with the nasal mucosa. So certainly an added option when you don't have those traditional options. And if you make the incision right in the glabella in one of the creases, you can see that the patient actually heals excellent. So this was 6 weeks post-op. So finally, the top of the ladder is the free tissue transfer. This is really when you have to pull out the big guns, so to speak. In our experience, one of the things that we've seen is a lot of success with patients surviving and the treatment for skull-based malignancies or head and neck cancers as well. But the problem is that they'll get really bad osteoradionecrosis, and that can be a tremendously debilitating problem. It can cause infection, pain, etc. And the key is to get their debrided tissue and put vascularized tissue. But in this location, like for example, along the clivus or cranial cervical junction, it can be very, very challenging. Here is a case of a situation of a patient that had osteoradionecrosis, persistent infection. We can see we're debriding a lot of the infected area there. And then the next step is you just really clean out that area, you debride the tissue. And this is where our reconstructive colleagues are really amazing. You know, they're the ones that make this almost like a spaghetti and meatball free flap. They connected the flap into the facial vessels, tunneled it in through a buccal incision through the maxillary sinus. And then after we prepared and had debrided, we laid it down. But the patient was able to swallow just fine because there was no impediment in the closure of the soft palate with the nasopharynx. This is another case of a young patient in his 20s who had a very terrible rhabdomyosarcoma, had been treated with chemotherapy and radiation. And actually the lesion itself that was there looked like recurrent tumor, but it was all necrotic tissue. And this is one that we repaired with the technique that I just showed. Here's a case that we did a couple weeks ago. It is a very strange clival defect caused by a cocaine-induced vasculitis. It's actually one of the agents that is used to cut the cocaine that causes an ANCA-induced vasculitis. And she had a skull-based defect. There's herniation in the brainstem going through this defect. And so we were left with the challenge, how do we fix this? Here you can see in the middle is the little bit of the defect pooching through. Here we were taking this covallator instrument and really trying to get to bony edges. Once we've been able to delineate the bony edges, then we dissect a little bit more, try to free up that adherence. We did have a lumbar drain in place, so at this point we started draining CSF to try to help that encephalocele to reduce. And then once we had final reduction, then came the reconstruction. Now, part of the reason why we decided to use a free flap in this case was because of the highly unusual nature of this defect. Certainly by getting good vascularized tissue on the bone, the idea is that we would hopefully create a much more solid barrier should there be any more bony problems. Here you can see the reduced encephalocele. The patient was becoming paraplegic and had improving strength by the time of discharge to rehab from the hospital. Just a couple notes on emerging concepts. We've talked about going up the ladder. What about going down? This is de-escalating. Can we de-escalate? So convert a high flow to a low flow or no flow situation. Well, this is something that actually comes up in these diaphragm defect scenarios. We have a large pituitary tumor. We've all, for those of us who do pituitary surgery, we've all gotten these leaks. But then if the defect is small, we actually can trap the diaphragma defect in the suction, as you can see, and apply a clip in the diaphragma, across the diaphragma defect. And then here we can see we're going to Valsalva to really test, is this clip holding? And it is. So at this point, we took a high flow leak entry to the basal cisterns into a low flow leak scenario. And so this, we put an additional clip there to hold. And this really changed our way. Instead of doing a large nasoseptal flap, for example, we actually repaired it in the way that we would a low flow leak. We weren't so courageous to say we're going to do no repair or repair it the way that we would and no leak, but we sort of de-escalated. So key takeaways, this latter concept can help frame options for reconstruction. The nasoseptal flap certainly is a workhorse for high-risk defects, but it's not actually needed for every case, and it can be tailored. And then there's newer strategies to potentially de-escalate reconstruction needs that may be as effective and speed up recovery. I want to thank what you're seeing is just me representing an entire team of people at the Cleveland Clinic who are doing this work. So I appreciate the time and opportunity to be here with you today.
Thank you very much, Pablo. Thank you for your great presentation about the ladder. I think there is a great concept that fits magnificently into the topic of what we are presenting today. And what is the topic, of course, of this webinar. I would like to see if I don't know if you have any commitment, but probably would be nice if we have a couple of questions before you leave to...
I can stay on. I can stay on and
Okay.
at the end if you
Good,
wish.
good,
Sure.
good.
Why don't we go ahead then with the next presentation? And I'm very happy to introduce Mario Rigante to our group. We already heard his intervention and the question. Mario Rigante, he works now at the Ospedale Isola Tiberina, but he's been a partner for many years since my return here in Italy, in Rome. And he is a ear, nose, and throat specialist that is particularly focused on all the skull base and works very closely with Francesco Doglietto and myself. He will talk about the pedicle vascularized flaps in skull-base reconstruction. I would say developing even further some of the concepts that were introduced already by our previous speakers. So Mario, the floor is yours. Thank you very much for being with us.
Thank you, Professor Olivi, for this kind introduction. I think you already shared my presentation. I just quick move to some of the concepts that already the previous speaker speak about, and I hope that, okay, it moves. So when we deal with skull-base reconstruction, we need to remember that we deal with four different scenarios concerning different pressure, as already told, of CSF, and of course there are different pathway of reconstruction, if we mean anterior rather than medial or posterior skull base. We need that the key point is the relation with the cistern and ventricle, and concerning the posterior cranial fossa, the major cistern are quite important, and this is what we got ICSF leak, and then there's a different option that we need to deal, different reconstruction technique. So when we speak about reconstruction, we speak, of course, about endoscopic one, and we need to consider about the number of the layer that we will deal with before attending the surgery. And of course, the presence of the intraoperative leak, we need to classify according to Esposito Kelly. If we deal especially with pituitary surgery, I think that all of you know the grading system, and in which of these occurrence we need to deal with different strategies. Of course, when the multidisciplinary approach, as already all of the speakers told, concern about patient-related factors. Age is important, but also BMI, especially when we deal with obese patient, we need to consider how to reconstruct in the immediately post-operative period. And also if they already had previous surgery, now we are experiencing our first surgery in which we were too much demolitive in the nose. So we need to have some exit strategy. And of course, if the patient needs to be re-irradiated after our treatment, and of course, there are all the tumor-related factors are quite important or paramount important. During this section, we can have every heavy problem also concerning different kind of pathology, and we need also to take care about the extension and sites. The principles that are mandatory are to avoid any vacuum, so to fill every vacuum inside that can reduce the pressure of CSF leak. And of course, anatomical layers are important. We need to reconstruct dura, if possible, bone, skin, and mucosa. And also in the nose, we will see how it's important, how it changes also the scenario of CSF leak in skull-based vascularized flap that can be another important barrier. So, our priorities are not only watertight seal, but also if we need to irradiate the patient, so vascularized tissue, it's important to avoid osteoradionecrosis, and also to keep bulky substance to obliterate space. But we also need to think that this is the issue of quality of life to the donor side. Sometimes we move to the fascia lata, to autologous graft, and also to pedicle flap that are quite much more important than the reduced also the donor side morbidity. So concerning the autologous graft, they are important mainly when we use, for example, when we need bone and cartilage. Nowadays we use that rigid structure after the intradural layer. Of course, they are important, they are low cost, and they avoid the post-operative shrinkage. We remove this kind of, we does not prefer autologous graft, but we prefer at least when we can fat tissue rather than non-autologous grafted. Of course, today we will speak about focus on pedicle, and the workhorse is nasoseptal flap, but already told, but there are other different pedicle flap, and we speak about the nasal, and the other colleague, Francesco, will speak about TPFF and the other flaps. So when we deal with restoring level, we need to think all this factor, and of course the intradural phase, it's important. We need to obliterate excessive dead space, and especially in pituitary, we need to put something in the diaphragm to avoid the pressure, and also we need to avoid also to overpacking to make damage to optic chiasm. The dural phase, now we preferably use fascia lata, of sometimes we use some glues or hemostatic agent, but generally we prefer to put autologous graft. And this is a matter of debate, but generally we use a school reconstruction also if we don't have excessive CSF leak, the bony structure that can help us in the reconstruction of the pituitary part. But concerning the vascularized flap, we use nasal flap, especially to repristinate some autologous buttress to avoid excessive nasal crusting after the healing process, and to speed up this healing process. But let's focus on different scenarios. So in anterior skull base, we will especially use fascia lata in different layer, in layer infradural space, epidural ones, and then the third layer that can be extracranial, extradural. Of course, we in this case we are dealing with the nasal paranasal tumors, adenocarcinoma, or esthesioneuroblastoma, in which we cannot use pedicle flap, but in special in selected cases, as suggested by Italian authors, this was an olfactory one side esthesioneuroblastoma, that we can use a pedicle flap from the septum of the other side, what they call a flip-flap technique, that is can be important, the vascular flap, especially if we need to send the patient to radiation therapy. A different scenario, but this was a trauma in which we also use a pedicle flap. You see the free graft of turbinates after preparing the bed, and then the nasoseptal flap there. So this is a summary of all the vascularized flap, and the also they described it there in here. So the most famous is the Haddad one, but also Professor Castelnuovo and one of the school, Battaglia, described what they call the septal flap based on the anterior ethmoidal artery. The turbinate flaps are already used, but sometimes are demanding in harvesting, and we need to remove careful the bone, preserving the pedicle that comes mainly from the sphenopalatine artery branches. It supplies a good area, but not as good as the nasoseptal flap, and generally is used as a second strategy after, especially if we don't have available the nasoseptal flap. And there are also the other regional flaps that mainly are described, but other autos such as the TPFF, the pericranial fascia. The first description was by American and French authors that described the pericranial to a money box into anterior skull base. But let's focus on the what we use the nasoseptal flap is the workhorse. These are our first study of the vascularization based on nasoseptal branches of the sphenopalatine artery. So we need to harvest it. This is in the lab, but just to preserve it during the nasal part of our surgery before opening this sphenoid. And it's important to harvest and storage in the nasopharynx. There are different variation of the nasoseptal flap described, and we can change our incision and also coming and harvesting all the lateral aspect of the nasal mucosa. And of course, we can also study the limits, and we know that we can also reconstruct the anterior skull base. But there are some other description on this flap. We use generally the rescue flap because we need also to take care of the quality of life, because olfactory preservation is important, especially in the first study. They described that when you harvest the flap, you can observe a reduction of olfaction that comes in our study also later after 3 or 6 months. It provides faster recovery and also can provide a surgical freedom. We just make a variation and make an incision in posterior and anterior aspect, preserving the branches. This is how we harvest in the lab to show the vascularization. This is how is vascularized, preserving the anterior branch that can be helpful for another reconstruction. And this is just a case in which we can aspect before surgery the occurrence of CSF leak. We just made the rescue, making this incision and preserving the vascularization. So after removing of the pituitary adenoma, we didn't have leak, so we put back the flap, and we have back them for eventually next recurrence. And this is after 7 days. Also the nasal aspect, it's already healed, and we see the sphenoid cavities well vascularized. So we studied our rescue flap, and we just say that we can convert them in low percentage of cases, mainly in different, of course, meningioma and craniopharyngioma surgery. And we are just compared with our series with the other authors. So the other flap are the middle turbinate, and also it's quite difficult. Sometimes it's sacrificed during the approach, so remember that. And mostly the inferior one that can be helpful also for clival region, but sometimes it's got a memory, so in the nose we will observe more crusting and so on. And of course the other approach suggested by our friends of Naples, the other Italian group, they're also using only fat flap and fast flash mobilization technique that can be helpful also in the cella and supracellular region. This is what we call the other vascularized flap that can be useful for anterior skull base, already described by our previous speaker. And of course, there are also temporoparietal and free flaps that can be helpful in vascularization. So concern, we also have experience with nasoseptal flap also in children, and there can be some concern, but we use that, for example, in this 6-year-old lady, and we easily harvest after removal, so the intracranial bone, and then we put the flap, and we get good healing. But the good thing to observe is that we have after 12 years also a good presentation of the nose without any problem. So even harvesting the flap in children can be helpful. So the vascularization is not a problem, and also the development of the nose and also the healing process of the nose after too much years. Another case of a young guy, but I move faster because we observed a CSF leak after a huge prolactinoma that shrinked with medical therapy. So we removed the tumor and we put at that time an nasoseptal flap that they observe improvement and shrinkage of the tumor after medical therapy. And this is how appears the nose after almost 10 years. So other different scenario. So this is what we speak about tuberculous cell meningioma, in which we adopted the same technique. In this case, we harvest both nasoseptal flap because we need to decompress both optic nerve. So during reconstruction, all the phases with the intradural phase fat on the bony canal, we use a rigid cartilage and then the nasoseptal flap. And this is the post-op view. Generally, we perform a precox MRI to show also to check the vascularization of the flap. And again, another clavus chordoma in which the posterior canal fossa was exposed, but again here, and we have the same case of the colleague in which we changes our behavior. You see the pressure and the basilar artery there. And again, we shrink the defect and we reduce what can be a suggestion of the colleague before the pressure, and then we put the flap and both the flaps of the both sides. So it's a trauma in which the same thing with the pedicle with the advantage to have low morbidity and also to improve the healing. So the vascularized flap you see after just 1 month, they well recover, and also the mucosization of the nasal fossa in the healing process, it's paramount important. And also we can, if it's necessary, refer in case of tumor the patient to the radiation therapy. So other cases, but I move quick. Final remarks: when should we prefer a pedicle flap? Of course, when we experience high flow CSF leak with directed cisternal or ventricular communication, in case of clival, a large anterior skull base defect or a multi-compartmental defect, in case of course of revision surgery, when we need vascularization, especially when we need to refer them to radiotherapy, and if we need a rapid mucosalization and robust coverage of the critical carotid or neurovascular structure. Probably we don't require a pedicle tissue when we have low flow leakages in a defect where also the nasoseptal cannot reach the region, and of course when there are sacrifice of this region. So finally, we need to reconstruct our defect anatomically. We need to think about nasal approach and the potential flap before going to surgery. So, and also we need to think about oncology of the lesion and the pathology, because we need to understand and discuss multidisciplinary any potential recurrences of radiotherapy. And of course, intraoperative, we need to have some exit strategies. And I think that Francesco will speak about that strategies in which we don't have nothing to harvest and we need to other vascularized flaps. So thanks a lot for your attention.
Thank you very much, Mario. This has been very appropriate as far as the sequence of our presentations, and as always, we appreciate your significant contribution and, of course, your partnership. Now, I don't know. I think we can go ahead with our last speaker before we open for additional discussion. And it's a pleasure for me to introduce, last but not least, Francesco Doglietto, who many of you already know as an expert in skull-base surgery, and now certainly in charge of our group here of neurosurgery at the Gemelli Hospital, and for all purposes, my great successor. And I think that it's a pleasure to have him to talk about an additional focused topic about the reconstruction of skull base, in particularly the use of the temporal parietal fascial flap as an excellent rescue plan for skull base reconstruction. I really appreciate Francesco being here, of course, and the floor is yours. Thank you.
Thank you, Dr. Olivi, and thank you to the moderators. It's a great pleasure to be here. I enjoyed the previous talks, and fortunately enough, I will cover a slightly different topic. It will be maybe a little bit technical, but hopefully this will help the further discussion. This is my disclosure, which is really not relevant for the talk. So we've already heard about the revolution that we have experienced in the last 20 years or so. Endoscopic transnasal skull-based surgery is a true revolution, but 20 years ago, it was really evident that we were enlarging skull-based defects and we're really not fully aware of how to best close them. And as Mario pointed out, and also Professor Resinos pointed out previously, a nasoseptal flap is really the working horse of what we do in these complex cases. But I thought I would speak a little bit about the TPFF because I find that sometimes neurosurgeons are not familiar with this option. And this is something that was described again by the Pittsburgh group. And this is the first original paper. And what happened in my personal career is that I was lucky enough to be recruited by Professor Nicolai, who is a famous ENT surgeon in Brescia. And that's where I became familiar with the TPFF. And I find that this paper by Andrea Bolzoni still remains a clear paper in its anatomical description. And as you see, the group in Brescia was using the TPFF for reconstruction mainly after the resection of nasopharyngeal carcinomas. And then what happened in the following years, getting to know also the colleagues from Paris, in particular, Professor Herman, ENT surgeon, and Professor Bresson, amazing neurosurgeon, who worked together for many years. Well, I became aware that TPFF is really quite a very good option for the reconstruction of skull base, even if you are just doing a transcranial approach. But what I thought I would concentrate on today is mainly on what it is and mainly on its use for endoscopic skull-based surgery. And so really TPFF is not something that was invented by ENT colleagues. It was rather described and developed by maxillofacial and plastic surgeons to reconstruct skin and soft tissue defects in the cranial area. And then it was somehow adapted to the issue of skull-based reconstruction. And as you see from this nice image, somehow you can think of using both the classic pericranial flap and the TPFF, even in the same patient, because they are based on different regions. And if you look at the literature, you kind of have a grasp of who might benefit from a TPFF. So usually it's going to be patients who do not have any nasal vascularized flap. And so these are usually, as Professor Resinos was pointing out, the complex patients that are increasing in number because we are treating these patients nicely from not only a surgical point of view, but with all the adjuvant options that we have. But if you look at the literature again, it might be quite confusing. So a few years ago with a team here led by Dr. Levy, we decided to have a look at this systematically. So we looked at the surgical technique, we performed a literature review, and then we decided to look at our personal experience. So the surgical dissections were performed here in Rome in our dissection lab, which we call Surgeon. And this surgical technique might appear really quite complex, but in the end, it's just two phases. One is the endoscopic one, the other one is the cranial one. And for the ones who are not familiar with the technique, in the endoscopic transnasal approach, what happens is you want to go transmaxillary. So you will open the medial wall of the maxillary sinus. Here we're looking at the left side. Then you have a look at the posterior wall. You just remove the whole bone, trying to preserve the periosteum so that you don't have issues with the internal maxillary artery. And then really the key is you can deal with the internal maxillary artery the way you want. Sometimes you don't even have to sacrifice it really. The key is really to be sure that you have a nice view and access to the posterolateral angle of the maxillary sinus, because behind there you're gonna find the space between the temporal muscle and masseter, and that's where you will want to transpose your TPFF from above. As for harvesting the TPFF, I think it's something that all neurosurgeons are familiar with the anatomy. So it's just applying the anatomy we know to the concept. And the concept is quite straightforward. The vascularization is based on the superficial temporal artery. And the branch you want to preserve and develop the flap around is really the parietal branch of the superficial temporal artery. The team from Paris at the beginning of their career, of their experience, tried to develop also the TPFF on the frontal branch, but the skin there is thinner. It is for sure a flap that you need to develop at a very superficial layer, because you're just working below the hair bulb. And so there's a disadvantage in going on the forehead, because you might have small patches of skin necrosis, while the parietal region has a thick skin, so it's much easier and more convenient, even if you have small regions of alopecia, which is one of the risks of TPFF. So I think we all agree that we will develop the TPFF on the parietal branch. And what happens? Well, really, this is what you can harvest. So it's again from the very superficial area just below the hair bulb to the temporal fascia. Here you will have the superficial temporal artery, and then it's a matter of recognizing the fat pad and going pretty much subfacial, because you want to create a corridor again between temporal muscle and masseter. There's this instrument which I wasn't familiar with, but it's really a standard kit for percutaneous tracheostomy, which can be easily adapted to the task. And so this will go through and will end up in the maxillary sinus. And you just need to be fully aware that you don't want to twist the flap at this level when you transpose it in the nose. So what happens in the nose? This is the blue rhino. And once you have created this tunnel, you can pretty much cover quite large defects. As you see, this is the TPFF coming from the left side. So when we looked at the literature 2 years ago, as you see, the articles dedicated to the use of TPFF for scalpel surgery weren't that many. And even the patients weren't that many. And it was relatively easy to show that these are really complex patients, usually previously irradiated, mainly all of them with at least one previous surgery. And then it was actually interesting to also notice that there is a variation of the TPFF, which includes a portion of the contralateral temporal muscle that has been described and that has been used by some groups. And again, the transposition is not only intranasal, but sometimes is purely from a transcranial point of view, and some other times is also combined. If you look at outcomes, you're going to have complications. Maybe at the beginning, I do remember one case in Brescia where we were a little bit too close to the artery, so the TPFF was not efficient, so we had to harvest the contralateral one. But apart from the SDA lesion, major complications are really related mainly to the pathology that you are treating. What is interesting is that there aren't that many papers out there, although we will soon, I hope, get one out. There aren't that papers out there on quality of life, so on minor complications that might cause disturbance. Here, the main one is loss of hair, which is usually focal around the incision, and you will have patients complaining about chewing, but it's mainly due to the manipulation of the masseter temporal muscle, and then sometimes also the pterygoid muscles are manipulated because of the underlying pathology. So then we looked at our series. This was in a span of 2 years. As you see, we just used TPFF in only 5 cases, in less than 1% of our series. But, and so why speak of this? Well, we need to speak of this, I believe, because we are dealing with complex patients. You see some had already undergone multiple surgeries, radiation. As Professor Resinos was pointing out earlier, some of these patients had osteomyelitis from radionecrosis. So for sure, aggressive pathology, even if you speak of pit nets, because this one was a silent ACTH, the other one was a non-functioning that had already been operated 5 times. The other ones, as you see, were choroidomas and spindle cell mesenchymal tumor. Indications were really trying to create a sandwich as much as possible, as Dr. Rigante pointed out, to cover with a nice vascularized flap the skull base that might need irradiation. And as you see, we did have complications somehow related to the technique. One was a CSF leak that required us a reintervention. We did have a TPFF necrosis and a TPFF dehiscence, but both were in patients with radionecrosis. So again, Dr. Resinos pointed out how difficult that might be to treat. And free flaps might be a very good options because they're stronger than TPFF. What happened in the last 2 years? We somehow had this image that TPFF would always be a rescue plan. We got this patient who had undergone just a biopsy in a peripheral hospital, so we knew this was a pit net, but as you see in the nose, there was nothing else, nothing more to use. We opted for the significant intracranial component to go with a combined approach, and we opted for a frontolateral approach. And so we ended up doing a combined approach and harvesting the TPFF from the same side of the frontotemporal approach, and got a fairly good reconstruction of the skull base As you see, there's remnant disease here in both cavernous sinus, invasion of the skull base, but that was really helpful. Really happy because the patient did very well, as all young patients do, with improvement of vision. But unfortunately, what happened a month later was that we had evidence of a CSF leak, which fortunately enough, we just were able to treat fairly easily with a bit of repositioning of fat in the cellar region. But the TPFF was there, viable. It had already adhered to a lot of the skull base. So it was a nice and easy revision surgery, and the patient is back to his life and back to school. So my conclusions are that TPFF is really useful when other flaps are unavailable. It's effective and versatile, even in complex cases, because the other advantage it has is that you're harvesting it far away, usually from the radiation treatment field. It's really significantly thick and nicely vascularized if you compare it to our standard nasoseptal flap. And once you get familiar with the concept, you can use it even for pure craniotomic scenarios, for example, in anterior skull base reconstruction, which might have failed the pericranial option. And so what I try to convey to all neurosurgeons is I think it's relatively easy to get familiar with the concept. And it's really important that whenever we are performing a simple pterional approach, we preserve the superficial temporal artery, preserving the parietal branch. So you just sacrifice the frontal branch, and you will have that option if you get into trouble. And with this, I'm finished. Would like to thank Dr. Levy for pretty much everything he's done. An amazing job here in Rome, and the whole team that you see here is the result of his 10 years that he spent with us, and fortunately enough is staying with us even in his retirement, which is obviously not a retirement, luckily enough. And if you want to visit us, systematically, next year, we're going to have the second edition of this master, which is run in English, if needed, dedicated to endoscopic skull-base surgery. And if you just want to come and visit us for a few days, please consider this course. We have a few places left. It's 3 full days with 2 days of hands-on, half a day of live surgery, and there's experienced faculty from all over Italy. So hopefully I will see some of you in Rome. And with this, I'm finished, and thank you again.
Thank you very much, Francesco. Thank you for a great presentation at the end of a great webinar that was dedicated, focused focally to the reconstructive technique in skull-base surgery. Before I want to thank all the speakers, I want to open for any kind of questions that we might have for the 3 last speakers, and then I would give my final conclusions. Thank you.
Okay. Question to Dr. Pablo, because this forum is connected with WeChat, and on WeChat we have a young neurosurgeon. So there is a lot of controversy regarding the glue should be used or not, number 1. Number 2, if patient has rhinorrhea, lumbar drain should be put or reconstruction is the choice. Dr. Pablo, please.
Okay, so I'm sorry, Dr. Sinha. The first question was about glue, you said?
Yeah.
Okay.
The glue.
Yeah, this is an yeah, of the sealants. We obviously usage of dural sealants comes with a cost. I think the important thing regarding dural sealant, there's a couple points that I would make. We actually do use sealants on a routine basis in our cases. So the first thing is to remember that the sealants should not be used to seal a hole, right? They are literally just to hold things in place to reinforce that for a longer period of time. Because if you use it to seal a hole, as soon as that sealant disappears, that hole will still be there. So that's number one. The second thing is we don't use nasal packing anymore. We abandoned using, and I'm talking removable cotton nasal packing. We stopped using that probably about 8 years ago, and the packing that we use is some absorbable packing material. Now that has been perfectly fine to work together. We have not had problems with infection or anything else. But I have talked to colleagues that still use the removable nasal packing, and when they use the dural sealants with it, apparently had issues with infection. So some of it is tailored to what your preferred reconstructive techniques are in general. But I think as something that as a measure of support to hold your repair in place, we have found it very useful. You know, it'll mitigate if the patient has Valsalva, coughing, sneezing, whatever. The second question regarding lumbar drains, this is an interesting question, which we, even in our own group, my other colleague, Varun Kashetri, like, for example, with tuberculum meningiomas, he used fascia lata plus nasoseptal flap. I would use a synthetic button graft and lumbar drain, and our results were actually completely comparable in our own data. I know that there was a trial that was done a number of years ago from the Pittsburgh group that showed efficacy for lumbar drains, especially when you had a high flow CSF leak scenario, big defect. But frankly speaking, we've started to try to even move away after we did that analysis with ourselves, and we've started moving. Okay, can we do fascia lata button? I'm sorry, the synthetic button, nasoseptal flap, sealant, and no drain, because it's not without its issues either.
Pablo, what do you
you.
use as a sealant, Pablo? Just you mentioned that you use routinely the sealant, just to have an idea of how people are using their sealants around the world.
Yeah, we use a product called Adherus. It's a green sealant. I know that in terms of testing on how long the sealant stays in place and what the burst pressure, that's been one of the ones that has had the best efficacy. But there are others as well, Duraseal, for example, made by Integra. The ones that you have to be careful with are the ones that last for a very short period of time if you are using it with the idea that it'll stay a long time. So Tisseel, for example, generally doesn't have the burst pressure level support that some of those other sealants does, and it'll last a little bit shorter time.
Okay. Could I add a bit to the discussion?
Go ahead, because there is also a question from one of the speakers, but go ahead first.
Yeah,
I would love to hear how your input, Professor Doglietto.
No, I'm sure we agree, Pablo. But I see the question there, and I just wanted to dwell a little bit more, because they're asking if there's a CSF rhinorrhea in post-op period. Would you wait? Would you put a drain? I think I've become quite aggressive in, first of all, diagnosing a CSF leak You might have a doubt, which is easily resolved by just asking for beta trace, or if you don't have beta trace, beta 2 transferring. And so you will be ruling out whether you have nasal discharge that is normal or a CSF leak, to the point that we now diagnose the occasional CSF leak quite early when there's no air in the CT scan. Because maybe 15 years ago, I was used to looking at the CT, looking for air, but I then understood that that is a way to get a late diagnosis. And if I'm in doubt, well, if you have a CSF leak, I think you need to consider early revision, because your patient does not have meningitis. And so you need to ask yourself, have I done the best possible job? And so maybe at that point, if you're in a high risk scenario, you might decide to put a CSF drain in, which is what we would do in very complex and large clival defects, for example. But if you look at the Pittsburgh data, that was actually a prospective randomized study, so significant, their rate of CSF leak in the anterior skull base was really quite high. But I think that's because they were probably treating a lot of large tumors, including olfactory grooves, with a lot of empty space, while what we would treat here are maybe esthesios, or anyway, tumors that don't have such a large intracranial component, so that the frontal lobes in anterior skull base will immediately kind of seal the CSF space. So I think it's important that you understand what you're doing and the difference with the other centers. But our reasoning is we will try to fill the empty space, as Dr. Rigante pointed out. And then if we have a large high pressure CSF space, maybe we will put a CSF drain in. But if we can get the patient up walking around the day after surgery, we believe there's a benefit there as well. So Pablo, I'm not sure about your philosophy, but for sure, if we get a post-operative CSF rhinorrhea, we will try and find a small hole, maybe get the flap down, find a small hole, replace the flap, and that usually solves the issue.
Yeah. Before Pablo, before Dr. Racino's answers, just to know that one of the participants, Dr. Agrawal, was asking exactly if there is a rhinorrhea in post-op period, it's okay to wait for some time, or for that leak, or it can stop by itself, or it's better to go for surgical intervention directly. So that was addressed in part by Francesco, but let's answer also. Let's wait also for the answer of Pablo Racino's.
Yeah, I agree with you wholeheartedly, Francesco, that if post-operative CSF leak is not one where we will wait or just try to seal up with a lumbar drain in that case. In fact, a lumbar, depending on what you use for materials, I suppose it could work if it's like some fat that just sealed up. But in general, if there's a hole, that's usually not going to be very effective, and in some cases quite counterproductive. It can suck in air, cause pneumocephalus, if you have a ball valve mechanism with your repair. So we are, like you, aggressive. And it's a funny thing, as neurosurgeons, we view CSF leak like, oh, we have to take care of this quick. You know, where my ENT colleagues will diagnose a patient that has been leaking forever, book them for next month. And but they're two different situations, frankly speaking. You know, those are ones which don't often get impending meningitis, whereas, like, you know, a patient where we just did a big endoscopic skull base procedure, they're just different, right? And I think we are in agreement that we tend to take those patients back in the immediate time period if we've diagnosed them with a leak.
Thank
Yes,
you.
I can add a comment as CNT. We just
Yes,
need to
Mario.
also to check endoscopically if there is a leak or everything was washed out. We just put, you don't use packing, but the resorbable packing if you got a CSF liquid wash away. So just endoscopically checking and send to DOR. So we no more use the CSF drain, the lumbar drain. We used at the first experience almost 10, 15 years ago, especially in child to keep them in the rest bed. But now we also don't use them also in the special population, but we move directly to the OR. If we can, we do an endoscopic evaluation before sending, just to know what happens if there's something that was wrong with our reconstruction. So generally the cooperation leads to this, so we can, Francesco call us and then we check them, and if there's a leak, we go straight to the OR. Don't wait for this. A different scenario is what you say. In a spontaneous CSF leak, probably now we got some cases in which we can use, but it's a different scenario, different pathology. So it depends from other issue, and I think it's not the topic of this discussion.
The one thing that I'll say, like when we use like posterior fossa cases, as Francesco has pointed out, those are really high risk, scenarios. That's scenarios where we will use drains. And in any scenario when we use drains, one of the things that we've actually started to do is we'll clamp them and then we'll drop intrathecal fluorescein after we've clamped, and then we'll just observe, until the next day. Make sure that there's no leak, and then pull the drain. Maybe it just makes us feel better, but certainly it's another potential marker
option
to confirm that you have a good seal.
Yeah, I totally agree. Even in a post-op CSF leak, we might go for lumbar puncture just to check whether there are already signs of infection. At the same time, inject fluorescein, and then maybe 6-9 hours later, get the patient in the OR, and we are sure that we're gonna find the right spot for the leak, especially in large cases where Mario has already checked the patient. And going back to the sealant is really nice. We put gel foam and a bit of sealant in the sphenoid, and it's really nice to have that view of dry, really ugly, black, oxidized blood, which tells you that there is nothing washing, while when it looks nice pink mucosa, that's a sign of emergency, because there's probably a CSF leak that might be low flow at that moment, and that's when we want to diagnose it, ideally.
Thank you. If there are there any other questions? Dr. Sinha, do you have any other things to add?
No.
Otherwise, I would like to make some conclusive remarks.
Dr. Hirotaka want to speak something. Yeah, Dr. Hirotaka.
Oh, yeah. Can I ask a question?
Yeah.
Perfect. Yeah, thank you very much. So my name is Hirotaka Hasegawa from Saitama Medical Center, Saitama Medical University. I wanted to ask Professor Lestino regarding the usage of the rigid reconstruction, because I don't think you talked a lot about rigid reconstruction. So what do you think about the indication of that?
Yeah, I know that, for example, for a first layer, I had mentioned this button graft concept. The other side of the coin was a gasket seal, which would use a rigid reconstruction. We don't use it. We don't actually use rigid reconstruction ever, really. That's not to say it doesn't work. I just think it's just a different application, more because we've been using more this button concept, and followed by, for take an example, large defect, high flow CSF leak. Our reconstructive philosophy is on multi-layer reconstruction. The button, for example, subdural space, epidural or onlay, followed by the vascularized tissue. So in those cases, we don't use it, but from the outside, we still use the absorbable packing material. We'll cut nasopore, for example. It's like a rigid gel foam. We'll put that in the back area. But we've also evolved, like when I trained, with atomization, for example. I mean, we were still putting nasal Foleys and having that for a period of time. My partner Raj Sindwani quickly got me out of that. But we don't use the rigid reconstruction.
Sure. Thank you very much.
Sure.
Thank you. So I don't know if
No.
Yes, any more questions?
Yes. Now, over to Dr. Almendo for closing remark.
Yes.
Our co-chair.
Yes.
Dr. Almendo, please.
Thank you. I would like to thank all the speakers for their brilliant contribution. Today, we learned a new concept and reinforced other regarding school-based reconstruction. After the excellent discussion, it only remains to thank the Professor Debra Raj, Professor Pablo Recinos, Professor Mario Rigante, Professor Francisco Digliete, Professor Alejandro Olivi, and Dr. Virendra Sinya. Have a wonderful day. Thank you very much. And thank you, everyone who going with us via Zoom. Thank you very much.
Thank you, Dr. Alpizar. That was great. I want to join you. I want to join you in just thanking personally all the exceptional speakers that we had. They are both people that I worked with and former pupils, some of them. And to me, it's a pleasure to have such a high-level webinar on this particular topic. And I'm obviously going to thank Dr. Sinha, who was the driving force behind this webinar. And thank you all for the participation and the contribution. I think that we recorded that, so we ask you also the permission to distribute this recording because the people that for some reasons were not able to participate. Thank you so much, all of you. I think that
thank you very much.
Close.
Thank you.
Thank you, Dr.
See you.
Alpizar. Thank you, Dr.
Thank you.
Sina, and everybody.
Soon.
Thank you.
Thank you. Thank you,
Thank
everyone.
you. Bye-bye, everyone.
Bye-bye.
Bye. Bye-bye. Bye. Thank you.
Bye-bye.
Wonderful meeting.
Thank you, Dr. Sinha. I was very happy.
On WeChat, we had about 300 people.
I'm sorry?
On WeChat, we had 300 people watching this webinar.
Yes,
300.
Yes. Yeah, very good. Thank you. Thank you.
Thank you.